Good morning. So thank you very much for joining this KT seminar. It is a KT seminar. We branded it on medical applications, but in fact, when we were discussing with Anthony how to brand it, we say, well, in fact, it's a bit between a medical application, but also entrepreneurship. We also have a series of seminar on entrepreneurship. And so I think Anthony is going to tell us a little bit about the two parts of the story of the company. Both what they do, but also how tough it was to create this company. So I'd like to introduce Anthony Butler. He's the Chief Medical Officer of Mars Bioimaging. Mars Bioimaging is a company which has a license on the Medipix technology and is a long-standing partner of Medipix. And well, I'll give you the floor, and thank you very much for joining us all the way from New Zealand.
Yeah. So, thank you, Giovanni. Yes, the microphone's on, I can hear myself. So today I'm going to talk about Mars spectral imaging, from high energy physics to biomedical business. As Giovanni said, I'm from New Zealand, so that's roughly beneath the feet, about 12 hours away. So why would a country and a person like myself be interested in working with CERN? So I'm going to answer that question and then talk about what we're doing to help the medical community, what we're doing to help the New Zealand industry, and how we're trying to make a difference. So, overview of my talk, I'm going to talk about a timeline of our involvement with CERN. I'm going to then jump back to some very basic sort of medical physics, what computed tomography is, how it operates in medicine. Excuse me. And then I'm going to talk about the spectral CT program in New Zealand, what we're doing to develop new imaging tools, a bit about the underlying technology, and then some areas of clinical impact, and then I'll wrap it up. Start with some New Zealand history. So I'm from Canterbury University, where I did my undergraduate physics. Our most famous graduate is Ernest Rutherford. So I work in the Rutherford building, and we have Rutherford's first labs, and we've got his medals up on the wall. Many physicists, of course, have heard of Rutherford. Perhaps less famous in the physics community are Bates and Peters, who in 1971 did the first Fourier transform in CT. In fact, it later became known as the central slice theorem and was the main method of CT reconstruction through the 70s. And in 1972, just after Sir Godfrey Hounsfield, they did a CT of a sheep bone. That's how you know it's a New Zealand image. Excuse me. So I'm going to also, CERN history. CERN's been working in this area for many, many years. Eric Heine, who works here, was one of the people who developed some of the first photon counting detectors, silicon strip detectors, and then in the mid-90s, Michael Campbell prophetically said that various applications like medical imaging should profit from this. And remember, that's mid-90s, so 20 years ago. So this is a timeline of New Zealand's involvement in CERN, and I did wonder how to declutter the slide and how to organise my talk along the slide. So what I'm actually going to do is talk you through the involvement, then I'm going to break out and talk about the various parts in a more kind of logical way, and then come back to the timeline at the end. So New Zealand scientists started collaborating with CERN around the year 2000. In fact, it was a Canterbury graduate who came here after his PhD and worked on the accelerator in CMS and convinced some of his old teachers in New Zealand that New Zealand should join CERN. In about 2001 or 2, I think it was, New Zealand government officially joined CERN as an associate state, I guess it is, or a non-member state, and signed up to the CMS experiment. About a year later, New Zealand got some money to do some detector development, and in that very first application, and it wasn't a big application, they got about one person's salary for 3 years. They said they would do high energy physics and consider medical applications. Soon after that, actually, they sent a student through the summer studentship program to work with the Medipix group, who worked with early Medipix 2 detectors, and then brought one back to New Zealand and convinced a couple of medical physicists to get involved. At that time, I actually came to CERN and met Michael Campbell. I had one day that was actually quite memorable for me, seeing the technology and going, yeah, as a radiologist, I'd just completed my radiology training, I'd just become a specialist in the hospital. I looked at this technology and said, why isn't this in the hospital? So we went back to New Zealand, we got a small group together, and at that stage we got a $1.5 million grant out of the New Zealand government, which was quite large at that stage, to do several things. A little bit of high energy physics, about a quarter of it. About a quarter of it was to put in place some technology for medical physics students, and then we had to put in some teaching courses and things. Shortly after that, we used part of that money for the University of Canterbury to join Medipix 3 when we built our first principal scanner. I'll show pictures of all these things later on. And we formed a company, Mars Bioimaging, so that was a spin-out company from the university. Using that proof of principle that we could actually do something a bit unique and that we could actually make it, we went back to the government and we got $4.5 million of government grant to do R&D, and we got several $100,000 of private equity. So actually what we did, which was a bit unusual at the time, is we presented to both the private equity firms, or the private equity people, and to the government a research plan, this is how we expect the technology to develop, and a sales plan of this is who we're going to get key opinion leaders early, it's not going to be a complete system. And that was actually a bit unique, and the New Zealand funding agencies thought this was great. Doing research, but actually thinking about how you get to the end. And we actually, right back then, also included, if we're going to do this sort of detector development for medical applications, we need to continue doing the fundamental physics research, so that funded quite a bit more work on CMS. We, at that stage, sold a few proof of principle machines, and we managed to, I'll show them a bit more, we managed to sign a research partnership with GE Healthcare, and that led to us getting $12.5 million out of the New Zealand government, which was about 3 times larger than any healthcare research grant that existed in New Zealand at that stage. And it was probably the only health grant that included doing things like neutron measurements. We were building detectors that go with the Brill Group at CMS. And we, at that stage, took on board some venture capital funding, and we called our project Taking Mars to Humans, which seemed to be a nice thing, because at that time NASA was talking about taking humans to Mars, and we thought it was actually much easier to go the other way around. We've now got a human translatable scanner, and these have been sold to reference sites in the States, and we've got a human scanner under construction. So that's a very brief overview of the timeline. I'm now going to talk about things in a totally sort of orthogonal way, which group more by the ideas and the concepts rather than along the timeline. So this is the team. We've got about 30 people in Christchurch at the moment. We've got 4 universities involved: Canterbury University, which is in the physics department where I am, and across town we have Otago University, which is a large medical school associated with the hospital. We have Lincoln, because they're the other university in town and they happen to do a lot of the animal research, and Auckland University, because they have a high energy physics program. We've got a lot of international partners, of course: CERN, Mayo Clinic, Rensselaer Polytech, Notre Dame, Oregon Health Sciences, and many, many others. Our commercial partners are Mars Bioimaging, and at this point I'll say I'm one of the founders of Mars Bioimaging and one of the major shareholders. And then we have a number of local companies that do a lot of the manufacturers for us, and internationally we work with GE Healthcare. So what is CT? What is all of this about? I've given you a lot of sort of concepts of timelines and all these grandiose ideas, but what are we actually trying to do? In the late 1800s, Röntgen, of course, discovered X-rays. It was only a week between his demonstration to actually taking it to the medical clinic and showing a broken bone on it. And it was only 6 years later till he got a Nobel Prize. So those sort of timelines are much faster than you'd expect to see these days. X-ray systems then developed. This is a typical X-ray system in use in a hospital in the early 2000s, of course. You have an X-ray source, an object that you call a patient, a detector system, and a pattern recognition system. I say this is the way it existed in the year 2000 because actually what had changed is very little. The detectors were still integrating detectors. The more X-ray systems the more X-rays that hit the detector, the more it glowed. You tended not to sit right in the main X-ray beam anymore. You tended to use a digital system to put the image on a PAX and look at it next door. You still had a pattern recognition system that was principally a radiologist, someone who had 12 years of specialist training, but it was getting more and more computer-based. But essentially the technology, the underlying detection system hadn't really changed. You had a scintillator that glowed when X-rays hit it, and you measured how much it glowed. In the 1970s, Godfrey Hounsfield built the first CT scanner, October 1, 1971, as I said, about 6 months before New Zealand built theirs. And he got a Nobel Prize for it 8 years later. This was commercialised as the EMI scanner. Yes, that is the same company that sponsored the Beatles, or the Beatles formed. So your Beatles music that some of you were listening to in the 70s paid for the development of CT scanners. This is what a CT scanner looks like these days. I consider them 3D X-rays. So you have an X-ray source shining a fan beam down to an array of detectors. Everything rotates round, and you reconstruct on a computer to get a 3D picture. They look like giant donuts. They typically weigh about a tonne. The rotating component weighs about half a tonne and rotates at about 3 or 4 revolutions per second, and the patient goes through it. This is the sort of picture you get off it. So you reconstruct on a computer, hence a computed tomography. This is an image through someone's chest. This person has lung cancer. This is just above the heart. So this is the aorta coming up and then going back down. And in here, all this grey stuff is tumour. So this person's got a nasty cancer. But as you can see, it's a grey scale image. All you actually measured is the attenuation at any point. Some things attenuate a lot, like bone and iodine, some things a lot less, like tumour, but actually you've just measured that attenuation. Excuse me. So what happened around the time I started training in radiology, I started radiology training in the year 2000, there was a huge upswing in the use of CT. It was going up by about 4 or 5% a year. And it continued on like that for about 5 to 10 years and then slowly plateaued off. At that stage, we had what was known as the slice wars. So this was actually a term coined by the marketing department of GE. We went from being able to acquire a single slice per rotation, so that's one row of detectors, to having multiple rows of detectors. 64 was pretty common. In fact, it's still probably the workhorse. You could get scanners with up to 500 or in fact 512 detector rows. So instead of acquiring a thin fan every time you acquired a fan that might be 1 metre wide and about 8 centimetres across. And that meant you could, from the single image, reconstruct in every direction. So they called it isovolumetric rendering, and you get voxels of about 700, just sort of 3/4 of a millimetre size, and you could see everything in all planes. But it's still grayscale, but you actually got fantastic imaging and really fast imaging. The current CT scanner in our hospital, our sort of workhorse, can go from the head to the toe in a few seconds, probably about 2 seconds. It can do stop motion imaging of the heart. You can see sort of the heart sort of beating, but of course you're going fast enough, it just looks like a freeze frame. So excellent spatial resolution, excellent temporal resolution. So as I would say, anatomical imaging is now really good, or morphological or structural imaging is actually really, really good. Molecular imaging is the future, so this is actually trying to measure something else in the tissues. What is the tissue is what we want to know. Is it cancer or is it normal? What is its behaviour? Is it rapidly turning over cells? Is it producing enzymes? Is it producing hormones? Is the treatment working? Did the drug I give that patient get into the cancer, or is it floating around in the blood system and not penetrating the cancer? So what researchers want to know, what are the constituents, and common ones that they're after are fat, water, calcium and iron. They want to use cancer and pathogen labels, and they want to use physiological markers. Which means we actually need to get more information out of X-rays. We need a fundamental change in the information provided by X-rays. And then we go back to school physics. So X-rays come in different colours. Depending on your high school physics teacher, they could be called wavelengths, frequencies or energies. It's all part of the electromagnetic spectrum. And X-rays, of course, here right up in the high energy, high frequency, but they still come in different frequencies or energies. This is a diagram of a standard single source CT. You have an X-ray source that puts out a range of colours of the X-rays. We'd use numbers like about 30 or 50 keV at the bottom of the red end of the spectrum, And at the high end, which would be the blue end, we talk about 120 kV or 140 kV. But maybe the easiest way to think of it is just low energy and high energy. You push them through the patient, they're attenuated, and then you have a grayscale detector, just like that picture I showed where the radiologist was holding a fluorescent screen up. A grayscale detector that the more X-rays that hit it, the more it glows. You don't get, you lose all that information about what sort of X-ray it is. And from that, you get a Hounsfield unit. Dual energy systems are becoming more common. We heard a talk this week at the workshop that CERN hosted that at Massachusetts General, probably one of the biggest radiology departments in the US, they currently have 15 CT scanners and 5 of them are dual energy at this stage. So dual energy systems work in a couple of ways, but the most common is to put out 2 separate energy X-rays, so 2 X-ray sources putting out different colours. They pass through the patient, and then you have 2 grayscale detectors, and then you get 2 points on the attenuation curve. It's a little bit more complicated than that, but not much. And that gives you more information, and they use it for things like CT heads, where they're wanting to tell if someone's has got a bleed into the head or got calcium deposition. The Mars spectral scanner, which incorporates CERN's Medipic detector, goes back to having a single X-ray source and a broad spectrum. So we put out a wide range of energies. They pass through the patient, and then the detector's very clever and separates them out into different energies. And so you get multiple points on the attenuation curve. Excuse me. So now I'll just talk about Mars Spectral CT program. So the goal of our program is to provide new information about tissues. What else can we learn about what's going on in the body? And we want to have a route to human imaging. Basically, when people develop X-ray tools, they're either going big, trying to get to humans, or they're going small, trying to see the smallest object possible. We're going big. We want to put people in. So we've called our system Mars because we've got energy resolution, spatial resolution, and temporal resolution, hence the Medipixel resolution system. The other reason we chose it, of course, Mars is easy to spell, sounds futuristic, and a good term to use for promotion. Single energy systems only have brightness, so if you remember back to those original CTs, they're grayscale. Things are either black, grey, or white. They've got very good temporal resolution and very good spatial resolution. So just to run over what spectral information can give, this is some old work, and I'll show you the scanner we did this on about 7 or 8 years ago. We talk about heavy atom imaging, sometimes called cage imaging. It's a little bit more complicated than just looking for the cage, but heavy atoms. So in radiology, we often use contrast agents like iodine, barium, and gadolinium. And these can now be used, if you can measure the X-ray spectrum, you can see these sharp attenuation peaks, which means that if we can measure the spectrum, we can use them in combination, and we can start using new pharmaceuticals. So one of the first experiments we did is take a mouse and we put barium into its lungs, and we put iodine into its heart, and of course there's calcium that's bone. So here's a standard X-ray of this animal, and you can see the bones are white, the iodine that went into the heart's white, and the barium that went to the lungs are white. And if you do a CT of that, it's white. You can probably, I haven't actually shown it this way, but you could look at the various amounts of it, but you'd never know whether you're looking at calcium, looking at iodine, looking at barium. Just going to go forward. Here's that same animal scanned on our first prototype system, where we could actually identify the colours. So although I've used red here to represent iodine, and it's in the left ventricle of the heart. Actually, no, that's the right ventricle of the heart. And we've got barium in the lungs. The colour I've given there is the X-ray attenuation. It says that is iodine or that is barium based on the spectral shape. We've done the same thing to separate out the bone and separate out the water or the soft tissue. And we've done it at fairly high resolution. That mouse is about 25 millimetres diameter, and you can see we've got excellent resolution of the internal structure of the bone. So our scanners, where did they start? This is Mars CT1. If you go back to the timeline, this was built in about 2006 or 7, just when we first joined CERN, or joined the Medipix collaboration. It was built in the physics department. It looks like a physics experiment. It was command line driven. It was hooked up to a MATLAB system. It used a Medipix 2.0, not even the later Medipixes, which was called MXRs. It was very slow, but we got that mouse off that. We then improved it a little bit. We allowed ourselves to translate the detector. We changed X-ray tubes. We put a system where we could change the detector from silicon to, at that stage, gallium arsenide. We were trying. The Medipix collaboration produced something called an MXR, which gave a slightly better and, well, more importantly, more stable image. And we took this from the physics department to the medical school, which had the advantage of being able to take things from the pathology department or from the operating theatre directly to the scanner. It's about a 100-metre walk from the operating theatre to the scanner. And so that was really important. We could start looking at bits of humans as they came out. Here, actually, though, it always amuses me, that's a picture of my lunch. So these photos were actually taken on the commissioning day, and I didn't have a test object, so that's an apple core wrapped up in Glad wrap, or saran wrap, I guess the Americans call it, with a twist tie around it, and it made a very good test phantom of solid tissues and metal. So we actually then took it one step further. This is after we got our initial private equity investment, and it was still using Medipix 2. We'd got a bit more money out of the government, and we built a scanner. We put it in a blue box. It was actually still command line driven and very tricky to use still. You really needed to be a physicist, but we shipped several of them, and the first one actually went to the Mayo Clinic, and that's Steve Jorgensen on the left there, who's the operator there, and actually that's my father. One thing I actually left out of the story perhaps was a slight oversight, that one of those first physicists to join CERN in 2000 was my father, who's a professor of physics at Canterbury, and he was one of the named investigators and is a member of CMS, and also the Medipix collaboration. And then we kept developing the system, so we've now got what we call a commercial release. It uses a Medipix 3RX detector. We've got CZT on it, so now we can operate in the energy range of 30 to 120 keV. That means the way the system's set up, whatever you put in there will be exactly the same as what you'd put in a human system. We've got continuous spiral scans, which means you have to put slip rings and things in there. We've got motorised collimators, motorised stages. In fact, there's 12 motors in there. We've got motorised filters, and we've got a modular readout for scalability. It's designed for biomedical users. All the detector calibration is now automated. Once you hit start, it'll acquire the data. You get automatic recon into 3D, and you get material decomposition, so that's taking it to the various materials. It uses standard medical formats like DICOM, and we've developed some visual analysis tools. We've got one of these scanners in Notre Dame in the US, one in Rensselaer Polytechnic, and University of Otago's medical school. This is the visualization tool we've got. We had to build, this is not surprising I guess, there were no tools for analysing spectral data, so we ended up having to write some software to do that, and that meant we had to develop 3D viewers. Along the way we actually built a stereoscopic viewer, so this view here, if you put on 3D glasses, the object sits out in space from the screen. You can hold a stylus, and in fact you can take a cut plane like they're doing here, so this person's got that plane, and the weather slicing that through the object, you get high-res 2D views on the other screen. And so this is the setup sitting in Notre Dame. They have an imaging lab where they've actually got 4 or 5 different scanners, and this is our one there. So microchips for X-rays. Funny topic to do it soon. So as I said, we've joined CERN officially in 2002 when we joined the CMS collaboration, and in particular we work with the Brill group who do a lot of the beam monitoring. About 7 or 8 years ago we actually worked with them and put neutron detectors in the CMS cavern. A group from Prague, CTU, Czech Technical University, did exactly the same thing and put them in the Atlas cavern, and we still have PhD students who are now intending to put, and then initially Medipix 3 in the CMS cavern, and then hopefully a bit later on TimePix. This is I guess, an example of how long we've been members of CERN. This is CMS when it was still above ground. That's my father and I looking at it just before it was dropped down the hole. Are you allowed to say that you dropped the CMS detector down the hole, or was that a bad description? Carefully lowered it down the hole. I'd like to talk about the Medipix 3 and 4 collaborations. Canterbury's been a member of both. Medipix 1 started in the mid-90s. Medipix 3 has about 23 institutes, and Medipix 4, which started at the end of last year, is up to, I think, about 14 institutes. It's a fairly big and broad collaboration, and a very nice collaboration to work with. They've been transferring CERN high-energy physics technology into medicine for a long time, and actually other applications, to be fair. They've got a number of partners doing quite a wide range of things. New Zealand does a lot of the testbed type stuff for the medical applications, do a lot of medical application development, and we've done the first clinical experiments. This is a photo from a meeting that was held in Prague 5 or 6 years ago, and you can see there was actually quite a lot of people attending. I think it's about 60 attended that meeting, and of course for any collaboration only a third or a half make any meeting. So to put in perspective, I suspect Medipix 3 and 4 probably has more than 100 people working on it at any one time, probably more, I would guess. This is a little bit about Medipix 3. So Medipix 3 is a hybrid detector. This is a schematic of it. You've got a sensor layer, which can be silicon or gallium arsenide or cadmium zinc telluride. We typically use CZT because it stops high energy X-rays. We use it in a spectroscopic mode where the sensor is bonded to the underlying ASICs every 110 micron. It's got about 5,000 transistors in that pixel. Each pixel is communicating with its neighbour, and we get 8 energy bins out, 5 which include something called charge summing, that I'll talk about in a moment, and 3 that are non-charge summing. There are many other modes for Medipix, so I won't go into those now. This is Medipix 3's charge summing. One of the tricky things about photon counting, which is what we're using, is when a photon interacts in that sensor layer, it produces a charge cloud, and it's that charge cloud you measure. Now, unfortunately, that charge cloud can be quite big, both through electron drift and the height of the sensor and the bias, but also because you get secondary events. So some of those secondaries can move up to 140 micron, in fact, a mean path of about 140 microns in CZT. So that has an intrinsic problem of that one incident photon can be seen by 2 pixels. So that's a little bit bad for spatial resolution, but terrible for energy resolution. So one photon of 100 keV will be counted as 2 events. One of them might be 30 and one of them might be 70. So you've immediately degraded the spectrum. So as I said, one photon of low energy can ruin the spectrum. Now, what Medipix 3 does, and this is actually tricky and very clever, and CERN developed it over the last 10 years, is the pixels communicate. They say, aha, my neighbour had an event, I had an event, it happened at the same time, let's add them together and allocate it to the pixel with the highest. So here's some work that was actually done at Karlsruhe Institute of Technology by Thomas Koenig. If you switch that off, which is a single pixel mode, the dotted line, and put it in front of an americium source, the spectrum's very, very blurred out because of that charge sharing. If you switch on the charge sharing mode where the pixels communicate, you get a really nice clean spectrum. There's some secondary effects because of the cadmium escape and slightly outside of the size of the pixel, but as you can see, your energy resolution improves dramatically. And that becomes critical for doing material decomposition or identifying the materials. You need that spectral information. This is a Medipix 3RX detector, 14 by 14 millimeters, lots of wires coming off the side, and a little circuit board for holding it. We build these up into cameras. This is a 5-chip camera, so you can see we can, in theory, keep going as far as we want. We're actually in the process of building a much bigger camera than 5 chips. Each chip has a single readout board which contains an FPGA, a couple of gigabytes of RAM, and an ARM-based CPU. We have one high voltage across the whole camera, and we've got hardware synchronization, so all of them act together. And by having memory quite close to the chip, we can read that data out much slower. So we take all our images and read the data out slowly. So where's all this going? I've talked about some technology, I've talked a little bit about CERN, I talked about medicine. Why are we doing this? What are the clinical benefits? Well, fortunately, we have a medical school down the road and they've been working on this for about 10 years. What intrigued me actually is that very early on, many of the researchers in the medical school got quite excited, but it actually has taken several years for people to really get to grips with what can be done and how to do it. And so the number of results has been accelerating. It's perhaps typical of science. It's a good idea, let's try it, and until you're on your about third attempt before you get some nice results. So grayscale to material imaging, the spectral data allows you to identify and quantify different materials, and you get a map of each materials, and we can fuse these together. So, and the materials, we actually get the partial density in grams per cubic centimetre, and we assign a colour for easy visualisation. If we do a standard grayscale CT, some of these are bright, some of these are dark. Some of these are calcium, some of them are water, some are gadolinium, some are iodine, some are gold. You can see it's actually really hard to tell which is which. Here we've assigned colours based on the spectral information, and we can see hydroxyapatite, which contains calcium, gadolinium, iodine, gold, water and fat, all as separate materials. So suddenly we can actually start seeing stuff and knowing what we're looking at. This data set's actually available, and I've got the link there for anyone who wants it. You can contact the author. There's a number of people out there trying to do this sort of signal processing, and we make the data available for others to use. So what does that mean? You can do a mouse and do the same sort of tricks. So in this image, this mouse has had, I'm going to have to actually flick to the next slide to remember what it's actually had in it. It's had a whole lot of things injected into it. You've got the intrinsic contrast of the calcium, which is the spine and the legs and the chest and the skull. We've got water, the soft tissues. In this image, we've taken off the front part of the mouse or the side of the mouse so we can look inside and see the materials inside. If I get this right way around, these are the kidneys, and that's the bladder, and you can see the collecting system of the kidneys and the trabeculi within the mouse's bladder. And I'm pretty sure that was done with iodine, so that was injected about 15 minutes before the mouse was sacrificed. In the heart, hidden a little bit behind the rib cage, we've got gadolinium, and in the bowel we've got gold. So now, if you go back to that original image I showed of the mouse, that was about 3 days of imaging of that animal, or like 2 days of imaging on that animal, and about a week of processing. This animal was imaged in about 10 or 15 minutes, and the data was available for looking at on that 3D workstation about half an hour later. And of course you can split the water right off and see the materials. So you can see the difference between having just a CT, which is just those attenuations, and the benefit of just actually having the materials. Of course, when you start doing this, and this is actually really important, what sort of accuracy you can get. We can get most of them down to about 2 milligrams per mil, and that sort of limits what you can do, but it also gives a whole lot of opportunities. So we've got 6 projects running in New Zealand at the local medical school: soft tissue quantification, bone and cartilage health, atheroma characterisation, cancer research, metal artefacts and X-ray dosimetry. So soft tissue quantification, here's a bit of lamb chop. Again, you can tell it's New Zealand because we've taken a sheep to start with. And we've put it in a little tube and scanned it. This is a standard CT. It's a standard information at 1 energy, and we separated out the fat, the water and the calcium, and you can produce a composite image. This data is available as well. And if you render it with the right colours, it looks a little bit like a photo, and so you can see the marbling within the meat, etc. So this work was all about trying to really get that fat-water separation. It's quite tricky, but it actually becomes quite important, as I'll show you in a minute. We've started looking at the biochemistry around osteoarthritis. So osteoarthritis is the joint disease where the cartilage starts wearing away. People will know about it because they'll have elderly relatives with sore hips or sore knees, sometimes at the base of the thumb. Now, when that occurs, before the cartilage wears away, you start getting biochemical changes. You start losing the glycosaminoglycans. Well, it actually turns out that if you inject certain iodine-based compounds into the joints, they go where the glycosaminoglycans aren't. So here, And this is a human knee, by the way. This bit of cartilage is macroscopically normal. There's a normal amount of thickness. If you look at an ordinary CT, it will look normal. But by measuring the biochemical change, you can see that you've got those early changes of osteoarthritis. Now that's pretty helpful. At the moment, all we can say is this person who's had their knee out because the other side of the knee was really bad, they've had a replacement. We know that this person in the next 5 or 10 years would have got osteoarthritis. Now being able to know that is actually really important. At the moment, they're still developing therapies, but now we've got a way to measure how effective the drugs are, and so that will accelerate drug development. This is some work we've done in partnership with Oregon. We've been looking at osteoporosis. So one of the things that happens to elderly people, particularly postmenopausal women, is they get bone resorption, and they then fall over and break their hip. It's actually a huge problem because the hips don't heal very quickly in elderly people. They lose mobility, they lose independence, and actually I believe the 5-year mortality from a fractured hip in elderly patients is about 80%. So being able to monitor that disease is really important and monitor the treatment. Now, one of the problems is there's 2 parts to the disease. There's loss of calcium, so the calcium is washed out of the bone, and you can replace that. There's drugs that actually force the bone to take up calcium. But the other thing that happens is the bone structure wears away. The osteoclastic activity starts eating away at the bone structure. Now, normally you'd have to measure those on 2 separate devices, and it's a bit tricky. Whereas in the Mars scanner, you can measure the bone trabecular thickness and the cortical bone, and you can measure that at the sort of 50 to 100 micron scale, and you can measure the calcium. So now you've actually got a tool where you can follow the progress of osteoarthritis. You can start giving drugs and seeing, okay, it's making the calcium deposit in the bone. Is it actually helping the bone structure? Or is a different drug helping produce osteoclastic activity? Is that helping the bone remodeling? So a new tool that actually allows you to look at a very important disease in a new way. We've been looking at blood vessels as well. So there's a atherosclerotic disease. It's a cause of heart disease, it's a cause of strokes, it's a cause of intermittent claudication in the legs. So about 30% of people die because of cardiovascular disease. These plaques, or heart arteries you might have heard them called, they grow in the neck, they grow in the heart, they grow in the aorta, the big vessel, and they grow in the legs. The wall gets thicker, and it's actually a surprisingly poorly understood disease given that 30% of people in this room will die of it. There's all sorts of theories about the inflammatory process. Smoking's clearly very bad for it. It damages the artery wall. For a while they thought cholesterol was really significant. They're now starting to think maybe it's not. There's people looking at the blood vessels within the blood vessel walls, vasa vasorum, people looking at all sorts of things. But actually the tools for imaging this are actually surprisingly, I will say primitive. They're getting better. Tools like spectral imaging help. So here's a plaque that our biochemical people have been looking at. This is someone's neck, so this is this part of the blood vessel in the neck. This patient would have gone to hospital with what I might call a mini stroke or a TIA. They would have become weak in one arm, perhaps lost vision in their eye for a few minutes, and they come into the hospital and they had an ultrasound of their neck, and they've seen that the blood vessel walls thickened, and they'll take them to the operating theatre, they'll open up their neck and take out the inside of the blood vessel. And it's one of the nice things is for us is we can then take that down. I think we've done several dozen plaques at this stage and look at it. And so we can see that in this person's plaque, they had a very large lump of calcium and they had a lot of fat within the core. And so we can actually study that in ranges of plaques. And in fact, we're starting to look at some of the biochemistry that correlates with those changes. We've been looking at cancer imaging. This is a mouse where we use gold nanoparticles, and this mouse has had here a lung cancer stuck under them. So there's a type of there's a lung cancer where the cell line's called liver cells, and they've taken this out of humans. They've grown it up in a petri dish, and then from the petri dish they've injected it into the skin on a mouse, and then you grow the tumour. Well, you grow the mouse in the tumour. and then we've given these gold nanoprobes, and they've localised quite clearly to the tumour. They actually go to the kidneys as well, and so that gives us the ability to start imaging the vascularity of tumours. We started labelling individual cell lines. So, as I said, we grow these up, they're called cell pellets, and we haven't actually got them into mice yet. But in this phantom or bit of perspex, we've got some Raji cells, so they occur in lots of different cancers, and we've used some drugs, rituximab and Herceptin, you may have heard of the two of them, and attached gold nanoparticles to them, and then grown the cells in that environment, and we can get these Raji cells to take up the rituximab nanoparticle complex, and so we know in that vial there is that particular cell line. We've used the same cells and a control of Herceptin, which is another pharmaceutical, and they don't take that up. So we know that we now have a contrast agent that's specific for one particular cell line. Why is this relevant? Supposing you had lymphoma or breast cancer, and you've had a CT scan and they're looking at the lumps in your armpits and your neck and the back of the chest. They will look at that and say, has that got cancer or has that not got cancer? It's a slightly big lymph node. Giving these pharmaceuticals 24 hours in advance, 48 hours in advance, may allow that pharmaceutical to go to the lymph node, and you can go, yes, there are cancer cells there, or no, there's not. Okay, so those are really important things, and these cell lines actually become important because, particularly for these two, rituximab and Herceptin, these are pharmaceuticals, these are chemotherapy agents. If you can see that there are cell lines in someone's neck that are sensitive to rituximab, you will change your chemotherapy agents. So, important work. Yeah, and there's a scene on the 3D vial. We've been looking at reducing bone metal artefacts. This is a standard CT of a screw in a sheep bone, again from New Zealand. So this sheep has had a screw put into it. They close the wound up. They then put the animal back in the paddock for a few weeks. They bring the animal in and sacrifice the animal, and we've taken the bone out and then scanned it. And you can see that from the metal screw on a standard CT, you get lots of artefact. That's actually an artefact because standard CTs assume all the materials are the same colour, which the whole point of this is they're not. And here we've used a Mars scan, and we've narrowed the energy range we're looking at, and the same screw, you can see you get absolutely no artefact off it. And so that's actually really important, because if I look at this image, I wonder there where that black bit is that artefact, or is that bone not healed properly around the screw? Whereas if I look on the spectral scan, I can see that the bone metal interface is really, really good. And we did it it's actually the same shape, and you can see we get nice, pretty pictures. So this really does highlight that metal screw, titanium screw, is a different X-ray colour to calcium. And so we've had to label it as a different X-ray colour. The new wave of bone metal of implants, I don't know if anyone in this room's got one, they don't use cement, they use what's known as a tissue scaffold. So if you look at this is a porous scaffold. It's made on a 3D printer with pores of about 0.5 millimetre in size up to 2 millimetres. These things, the bone is designed to grow through them, so when you put them in, like a hip replacement or a knee replacement, you don't need cement. The bone grows through it and fixes in really permanently. The trouble with developing these things is it's actually really quite hard to see what sort of scaffold you want, what pore size you should have, how smooth should the surface be. It's easy to image the scaffold on a bench before it's in the bone, but once it's in the bone, it becomes much, much more challenging. And so here is one of these scaffolds. This is actually, again, being put in a sheep. So the scaffold's about 1 centimetre long and 1 centimetre wide. And you can see all the artefact off it, and so it's very hard to visualise that bone metal meshing. And here, on a spectral scan, it's really quite clear how the two of them have meshed together very nicely. And we can identify just the one material, the titanium material. As we wanted, we could just see the calcium. We started looking at gout. Gout is one of the things that was well known under dual energy to have some benefit. You could actually start to distinguish different types of gout crystals. This is a person's finger. Because of the type of scanner we have, the finger is actually no longer attached to the person. And we put that in the standard dual energy scanner we have in the hospital, and you can see the gout crystals around the joint. But you can see that it's quite low resolution. It's not very sensitive for the crystals. Whereas when we put it in the Mars scanner, you can see the crystals with much higher sensitivity. One of the nice things, I showed you the sensitivity tests we've got, so we know with 80% surety that every green dot there is actually a crystal. So we're seeing the much smaller bits of crystal with much more specificity. At the high resolution, we can really see this is a bony erosion that you get from gout, so this person's fingers sort of been eaten away. And so that would be very painful. That's why they had their finger removed. It was too much pain and untreatable. But for us, we can actually now use that and say, look, we can image gout much more clearly. When we get towards human imaging, that means we'll be able to, again, monitor treatment, monitor the drugs and see if they're helping. We've worked with the dosimetry service here at CERN actually to look at X-ray dose. At some level, we don't care if we irradiate a mouse or we irradiate a sheep bone that's been taken out. However, we do want to remain in the normal X-ray range. Our goal is to get more information, but with no more X-ray dose. And so this mouse has had gadolinium injected. I don't know, they just did that, I guess. And there's TLDs to measure the tissue dose. This is at the end of a series of experiments of measuring dose, first in phantoms and eventually in tissue. And depending on the protocol, we get 20 to 80 milligray, which is comparable to other CT systems. Intriguingly, we don't just get the picture of the mouse. Whether we want to or not, we see that the TLDs and the gadolinium are of different colour to the tissues in the bone. It's the advantage of spectral imaging. You get it whether you want it with these systems. So our current work is taking Mars to humans. This is where we were at 10 years ago. This is where we're at now. This is a human scale scanner, X-ray tube here. This is that larger 5-chip camera I showed you, patient bed. It doesn't look like a clinical scanner. It's much more flexible because we actually need to identify the diseases and how we're going to image them. So this allows us to try different collimators, different types of magnification, different scanning protocols, etc. We've got it in the physics department. We're commissioning it at the moment. We hope to have our first pictures out in the next few weeks to months. This one, once we've got it working, we'll either take this one or build a second one and move it across to the medical school for human clinical trials. So why are we taking Mars to humans? We want to grow the New Zealand spectral CT industry. As I said, we've got about 30 people between the university and the company at the moment, and a number of associated businesses. We've got partnerships with GE Healthcare, and actually so does the hospital. So we're part of the initiative in my city to build a medical technology industry. And we want to enable clinical trials. One of the things that's happened, as I said, when we first started working with some of the biochemists at the medical school, it took a long time for them to understand what the real uses were. And in the last few years, that's really accelerated. They've got their techniques together, etc. And so having a clinical scanner allows them to start, say, looking at the gout patients instead of taking the people with severe gout who are having limbs amputated, to actually follow drug therapy and just see what they're doing to those microcrystals and stuff with those patients. So this is really exciting. So just to review the timeline, as I said, I couldn't actually organise my talk according to timeline, but if we go back and say, look, New Zealand scientists, which was my father and David Krawczyk and Alec McPherson, who's still here, started working with CERN around 2000. New Zealand joined in 2002. We slowly built that up into a medical research stream. We've continued to do the high energy physics because we've convinced the government that you can't have technology spin-offs without the fundamental research, and we're heading towards human. So actually I think New Zealand's quite a good example of doing high energy physics research leading to the development of a high-tech industry, and I think that's for a KT seminar is quite a good lesson. New Zealand, we're a small country, we pick which international collaborations we join, and I actually had one ministry official say to me, generally they expect nothing back, but they have to keep trying. And this is one example where we can actually point to and say, yes, this is worth doing. So in conclusion, colour or spectral X-rays are the next step in CT. I'm absolutely convinced of it, and we had a workshop here this week really pushing that line. We had people from Mayo, Stanford, Hopkins, Lyon, at GE, Siemens, Philips, Toshiba, and there was a quorum of people who felt this is the way CT is going. I feel partnership with CERN has been mutually beneficial. It's certainly been beneficial to us. I hope it's been beneficial to CERN. And New Zealand's building a human scanner, and that's providing both health and economic benefits, which I think is really, really nice. So thank you for having me here, and I'm happy to answer any questions.
Thank you very much. Very inspiring talk. Are there any questions from the audience? Paul, if you can push the button so not everybody hears you.
So, thank you. It was really fascinating talk. You mentioned that the CT now has reached a level of performance in terms of resolution. Probably we can expect only marginal improvement in the future on that because we are already so good. But there is one aspect which is very important, and particularly in the context of molecular imaging that you have mentioned, which is becoming more and more important for the future, is the problem of the dose. And I'm working on the other side on the PET, but PET and CT are going very well together. And PET-CT is a very, very nice tool, in fact, for going to molecular imaging. And today, let's say the dose exposure, depending on the different protocols, but they are ranging between 10 and 25 millisieverts
That's
for
right,
the PET-CT, for the combination PET-CT. There is a market segment, if I can say like this, for PET-CT application, which is pediatric, which is very, very important. And when I say pediatric, it's going to neonatal and prenatal as well, fetus. And there's a recommendation from the International Radiation Protection, radiation protection, that for the fetus, the acceptable limit would be 1 millisievert.
Yeah, I've seen that.
So you know that.
Yeah.
So my question is very simple. With this new technology, spectral CT, you have the potential of so much improvement. So how can we, well, it can be used, as you say, for many applications and to increase the available information that you get from the image, but by how much can it be used to reduce the dose?
Okay, so I'll start with the dose thing, and I'll actually also like to use introduce the comparison of PET and spectral CT, because I think that's a separate and important topic. So moving from integrating detectors to photon counting, most people at this stage, there's a chap from Stanford, Norbert Palp, who's published quite a lot on it, talk about significantly lower dose. And the reason they talk about lower dose is the fill factor of the detectors is closer to 100%. On a standard CT, it's about 70%, so 30% of your detector area is just inactive because of collimators and segmentation of the scintillating crystal. So you gain 30% there. There's also some strong evidence that by having smaller pixels, you get better transfer of particularly the mid-range, mid-frequency information. And the question is, how much benefit do you gain there? Is it 10 or 20%? And then, so that's probably going to halve the dose, just from those two factors alone. Then there's a separate question, which is actually much harder, is a lot of the new reconstruction techniques, compressed sensing, etc., where you use sparse data and undersampled data, will make a huge difference in dose, way more than, say, 50%. And I suspect the photon counting will actually do better. Photon counting detectors work really well at low flux and very poorly at high flux. So if you're going to go to low dose, you actually want a detector that works better at low flux. So I suspect as we move to the more advanced reconstruction methods, the photon counting detectors will actually help. quantifying that, I mean, I could take a stab in the dark, and I've seen figures from it going to make a 10 times difference to a no difference, but it can't be worse. So I think going to photon counting alone is going to be an important step on the dose reduction pathway, but I don't think it's a complete answer. I think actually at least half the answer comes from better reconstruction. Having said that, you're absolutely right. In the paediatric range, dose is incredibly important, right? So I do a lot of obstetrics and gynecology, radiology for some reason. That's what I've been doing for the last 3 years. And we often do MR on the kids just because you don't want to do CT. By the time people get through to the 60, 70-year-old and they've got cancer, radiation dose becomes irrelevant. And so one of the things we've been pushing for getting more information out, and I think that's the real, in my view, one of the critical things for spectral stuff. The dose is going to help at the low end. And that leads on to the difference between PET and spectral CT. PET is incredibly sensitive, right? You can see very, very low levels of activity. The advantage spectral CT has compared to PET, and they are different advantages, is you can use multiple pharmaceuticals at the same time. So you might label 3 or 4 different cell lines with different markers, and I think that's quite helpful. You've got much, much higher spatial resolution. You'll be able to see the markers down, the 100 micron or 1 millimetre scale as opposed to a few millimetres, and that becomes quite helpful. But the sensitivity of spectral CT is going to get down to the milligram per mil. So we're sitting at the 1 to 2 milligram per mil, and we might get it down by another factor of 10. PET is 1,000 times more sensitive, or even 10,000 times more sensitive, and spectral CT will never get down that low. So I don't see them as one replacing the other. They're going to remain as complementary techniques in the same way, radiology departments have ultrasound, CT and MR. I don't see spectral CT getting rid of PET by any stretch. Another advantage with spectral CT over PET, though, is that the pharmaceuticals are non-radioactive. So if you've got someone coming in with chest pain, you can pull out of the fridge a pharmaceutical that maybe goes to activated platelets and look for the microhemorrhage in the plaque and decide this person's having a heart attack that way. To try and do a PET scan in the middle of the night is just impractical. I'm sure the big centres will do it, but my hospital will just never be able to have the technicians on site to do that. So I don't see PET going away. It's just so sensitive that it's brilliant for certain tasks, but this, I think, complements the whole molecular imaging tool.
Thank you. Are there any other questions? There's one there and then one there.
Hi, Anthony. Thank you very much for your very interesting talk. We can clearly see the add-on on anatomical information and qualitative information on the solution. But my question is, do you have any data on the general acceptance or the feeling of the clinical community on this?
What's the level of clinical acceptance? That's very broad, very big range of opinions. There are some people who say, 10 years ago when I started this, and as I said, 2005 I first came here, there were 2 views that people had. One, you can't do it. CT can never be done with photon counting. I think that's well and truly been established that you can. There's still issues around stability of the CZT, there's still issues around count rate, etc. But I think that question, at least in my mind, has been answered. I'm not sure everyone is satisfied yet, but many more people are. There's still the question of should you do it? And that's a much, much harder question to answer. I look at just even my local results, and I look at the results from people like the Mayo Clinic and Leon, who got the Siemens and the Philips scanners, and go, it's got to be helpful. But I don't think anyone has yet proved where it's going to help in clinical practice yet. But I don't see that as a problem. When I was a registrar 10 years ago, I used to have to take the ICU rounds every morning at 9 o'clock, and we'd just got our first multi-slice scanner in the hospital, and a patient had a scan, and one of the ICU registrars asked me, do you think cardiac imaging is going to become common on CT scanners? And I said, yes. And he said, but there's no evidence for it. And he was right, there was no evidence for it. We'd only just got our multi-slice scanner. They'd only been out for 3 or 4 years at the longest. And proof that it was better than catheter angiography in some situations actually takes 5 years of clinical practice. But I guess being a cowboy, I could look at the image and go, that's a better image, it's got to be helpful. But he was quite right, there was no evidence for it.
I think there was a question there, and then...
Yeah, hello. You've mentioned that you have developed some of your own software. Mm-hmm. So could you maybe describe what kind of algorithms and methods you use to data mine the raw data into such nice and clear images?
I will in general terms. So we have a two-step process. The first step is reconstruction as independent energy bins. So we reconstruct from the projections to 3D volumes at different energies, say 10, 30, 50 or whatever. That reconstruction step is a modified SART algorithm. So you can find that in the journals, it's pretty straightforward. The trick with it though is that using real data, your detector can be in a relatively arbitrary place in a spiral. We know exactly where the detector is, but they're not evenly spaced angles. Magnification's a bit difficult. The detector's never quite in plane, so you have to measure all the offsets. There's 27 free parameters in that, just for the geometrical parameters. So that's the tricky part in that, rather than the SART. So that's an iterative reconstruction. And then we have a material decomposition method where we take those energy resolved images and turn them into materials. We started out with very simple techniques like principal components analysis, just to look for difference across energy bins. And then there's a technique based on PCA for chemical analysis, and we looked at that for a while, and that actually was surprisingly successful. It's a cluster analysis in the eigenspace. And then we moved on to a different technique where we put a few constraints in, and that's where we're going to stop because we've got a patent that's not yet published. And so, yeah, it's a challenging thing. But what we patented, we call it classical MD in our group, and we talk about how terrible it is. And I was at this conference workshop this week, and actually I was reassured that it's no worse than anyone else's. It's a hard problem, and I think that reconstruction is going to be another at least 5 years, but possibly 10 years of research from the image processing groups. And in fact, you know, the obvious thing is it shouldn't be a two-step. It shouldn't be spatial reconstruction and material reconstruction. It should be done as one step. We actually did some work with Erlangen University about 10 years ago where we did it the other way around. We did the material reconstruction, the projection space and the sinogram space, and then did the spatial reconstruction second, and we found that introduced too much noise. But the obvious physics answer, it's not step one, step two, or it's two then one. It's one problem, and it needs to be treated as one problem.
There was a question there.
It was in fact the same question. Thanks.
I think we have time for one more question, if there is one. Yeah, there's one.
Oh, is it working? Okay, all right. Thanks so much for the talk. I was wondering, when you show us the different materials that defining what's inside in the animals, is there any limitations on the detection of the material? More specifically, do you actually input the individual materials inside your system? And if there's any unknown substances inside of it, how do you define those things?
Yeah, so what we do is we have a calibration phantom. So we actually start by knowing what materials we're looking for. And we can do up to 7 materials, but you need to know what they are to begin with. And usually that's actually a pretty reasonable thing because you know what you put in the animal on the specimen. It does fall over because actually we often just start with fat and water, and then something goes into Perspex phantom, and depending on quite how the calibration's gone, it either gets assigned to fat or water or something. And if you start throwing in another material like fat, water and Perspex, they're so close that it actually ends up confusing the material decomposition routines. So yes, we calibrate on real materials knowing what they are. We've got 4 charge summing bins that you can adjust, and one bin called an arbitration counter, which is always set sort of at about 5 or 10 kV, and so you can't move that one. And then you've got 3 without the charge summing, and knowing quite where to put all those bins for optimum separations is an interesting challenge. For many years, people used to ask, how many bins do you need? What's the optimum setting? One of the things that we actually very quickly came to realise, unfortunately, you don't know the optimum setting until you've taken the image, because it depends on how thick the object is, what the concentration in the material is, and of course you don't know that because that's why you're taking the image.
Okay, so let's conclude the seminar. Thank you very much for the talk. Remember your time. Thank you.